is a complex disorder characterized by variable and recurring symptoms, airflow obstructions, bronchial hyperresponsiveness, and underlying inflammation. In susceptible individuals, the inflammation causes recurrent episodes of coughing, particularly at night or early in the morning, wheezing, breathlessness, and tightness and chest tightness. These episodes are usually associated with widespread but variable airflow obstruction that is often reversible either spontaneously or with treatment. Some causes is genetics and from the environmental factors like airborne allergens like dust mites and pet dander if you have pets, and viral respiratory infections like RSV and rhinovirus. Some basic role of medications are the quick relief medications are the short-acting beta 2 agonists that relaxes the airway muscles to provide prompt relief of symptoms. Do not expect them to provide long-term asthma control. Using the short-acting beta 2 agonist for more than 2 days a week indicates the need for starting or increasing long-term control medications. Long-term control medications prevent symptoms, often by reducing inflammation. These must be taken daily. Do not expect them to give a quick relief. By taking medications correctly, using an MDI, it's for ages over 5. Actuation during a slow, deep inhalation, followed by 10-second breath hold. Slow inhalation and coordination of actuation during inhalation may be difficult, particularly in young children and elderly. 50 to 80% of the medications deposit in the back of the throat. So it's really age dependent when using an MDI. A DPI can be used for ages over 4. A rapid deep inhalation is the technique, and minimally effective inspiratory flow is device dependent. Most children younger than 4 years of age may not generate sufficient inspiratory flow to activate the inhaler. The dose of the medication may be lost if exhaled back through the mouthpiece. The flow is dependent. MDI with a spacer can be used with ages of over 4. A slow, deep inhalation followed by 10-second breath hold immediately after actuation. Actuate only once into the spacer per inhalation. If face mask is used, it should have a tight fit, seal, and allow 3 to 4 inhalation per actuation. It is bulky. It is used for patients that cannot follow simple MDI instructions, that have a hard time with patient coordination and cooperation. A nebulizer can be used with any age, and it is used like having a slow tidal volume breathing with occasional deep breaths. Tightly fitting face mask for those who are unable to use a mouthpiece. You can use a blow-by technique, and that's just holding the mask or open tube near the infant's nose and mouth. Less patient coordination and cooperation. It's expensive and time consuming. Self-monitoring. You can self-monitor with knowing your signs and symptoms, or having a peak flow monitoring is appropriate for most patients. Evidence suggests the benefits are similar in both. Consider daily peak flow monitoring for patients who have moderate or severe persistent asthma, patients who have a history of severe exacerbations, and patients who poorly perceive airway obstructions or worsening asthma. And then to develop and review the action plan.